Welcome everybody. I'll just give it a couple more minutes for more people to come before we start the webinar. Great. Welcome everybody to this joint COCOS-IPF and European Lung Foundation and European Pulmonary Fibrosis Federation webinar to present the results of the COCOS-IPF study on which outcomes within care matter most to people living with lung fibrosis. My name is Steve Jones. I'm a former president of European Pulmonary Fibrosis Federation. I'm currently head the patient advisory group at the European Lung Foundation, and I'm a patient. I lived with IPF for 8 years before very fortunately having a lung transplant almost 10 years ago. When I say that IPF and other forms of pulmonary fibrosis is the most devastating disease, almost, I wouldn't say imaginable, but it's certainly a really terrible disease with a low life expectancy and a terrible and deteriorating quality of life over time. We're going to hear a lot about that today in the webinar from our two speakers, Fabienne Dobbels and Celia Schenk. I hope, I think it'll be extremely helpful for us as patients and for the clinicians who are joining us on the call today. The talk will be given by Professor Fabienne Dobbels from the Catholic University of Leuven in Belgium. She's a psychologist who focuses on people living with chronic diseases from both a medical and a psychological perspectives, and patient involvement is critical to all of her work. As I say, Fabienne is the lead researcher on the project, and Celia Schenk, who's with her tonight, is a clinical psychologist at the Berlin University of Psychology. Her work focuses on the role of psychological factors in chronic physical illnesses and how this, a better understanding of that can improve patient outcomes. So we've got two people who spend their professional lives focusing on the needs of patients living with chronic diseases such as pulmonary fibrosis. Before I hand over to Fabienne to start the webinar, a couple of housekeeping points. You'll see from the screen here that there's a Q&A button at the bottom. The Q&A button is the one we use to put questions. Please do not use the chat function. The chat function will not be used during the webinar. But also, please don't put your questions in the Q&A until the end of the presentation. The reason for this is that Fabienne is going to ask one or more questions to the audience, and we want to leave the Q&A as the place where you will respond in a free flow way to those questions. And I think it's going to be really important to hear from you in that way. When all that's over, you can then begin to put your questions into the Q&A. When you do put your questions in, please make them short, succinct, and to the point. Don't put in general comments and opinions. Try and keep it as focused as you can to give the speakers every opportunity to come back to you with an answer to the point that really you're concerned about. Finally, I'd just like to point out that there's a translation facility at the bottom. If you go to show captions at the bottom of your screen, the CC button, click the arrow next to it, go to translation, switch translation on, go to my speaking language, and then you see on the right of the screen, you'll have a lot of languages, something probably more like 30 or 40 languages, and you can have captions in all of those languages if you switch your language on. So please do that. Please don't struggle with English. If it's not your native language and you don't feel comfortable with it, go into your own native language and have captions. Well, without further ado, it's a great pleasure to hand over to Fabienne Doebels from the University of Leuven, who's going to give the webinar today. Fabienne, looking forward to hearing from you.
Thank you, Steve, for the introduction, and also on behalf of the entire COCOS project team, a warm welcome to all of you. And it's really a pleasure to share the results of the COCOS project with you. After all, you're the beneficiaries of this undertaking. Why are we doing this project? Well, we know for a very long time already that the current follow-up for people with lung fibrosis mostly focuses on medical needs. For some of you, it takes some time before you actually get a diagnosis and receive treatment. For some, this means they have to take medication that doesn't offer a cure, but helps to slow down disease progression. But most of this medication comes with side effects that need to be monitored and managed. Physicians also follow the lung function because this gives an indication on where you are in your disease progression. And some people, as Steve also mentioned, suffer from some debilitating symptoms, such as shortness of breath or cough, which can be very annoying. Of course, these medical needs deserve attention and are very key to the well-being of people, but many of you also know that there's more in life than medical aspects alone. So many of you tell us that they experience symptoms of emotional dysfunction, they experience anxiety, feelings of depression, and this disease also has a huge impact on your ability to work, your social functioning, your family life as well. So unfortunately, until now, these non-medical needs receive very little attention within our models of care within Europe. So many patient organizations, as well as professionals, for a couple of years now, advocate for a model of care that pays attention to both these medical and non-medical needs of patients with lung fibrosis. But of course, before we can address these needs, we cannot cover everything because time and care is limited. So the healthcare professionals want to know on which aspects of health they should focus within their consultations across Europe. So in other words, what do people with lung fibrosis deem the most important within their care? There's variety in what people need and what they expect from care, but maybe we can find a common ground that is applicable to the majority of people living with lung fibrosis across Europe. And so this is why 3 years ago we started the COCOS-IPF project. So COCOS stands for co-designing a core outcome set for and with people with lung fibrosis in Europe. And so the goal is to develop a core outcome set, so a key set of health aspects for clinical care that should be addressed within clinical care within Europe. And we designed this key set of factors that matters most, not only for people living with lung fibrosis, but very uniquely together with people with lung fibrosis, because after all, you are the real experts. You know what it means to live with such a serious but rare disease. So I'm very happy to introduce you the COCOS project team, and many of the team members are also online. So welcome, colleagues. It was a pleasure working with you the last 3 years. So we had a great team of course, lung specialists. Maybe some names are familiar to you. We have Professor Weus, Professor Michael Kreuter, Dr. Vivian Simogoy, Professor Nesri Mogilkoc, and Dr. Noor Touraine. There are also some psychosocial scientists involved. As you've heard, we had psychologists, but also nurses, biomedical scientists, even a physiotherapist, and you see all the names there. Partners from Leuven, from Berlin, and from Izmir, so a very international group of collaborators. But I think the key partners here are the patient advocacy organizations. And so we were very grateful to be able to work together with, for instance, Janet Boyle, but also Lucy Robinson and Pippa Powell, Polina Sarkenko from the European Lung Foundation, and with Steve, Liam Galvin, Alba Ubide, Anna Spindler from EU-PFF. They were not only partners in this project, but we involved them as true co-investigators throughout these 3 years of the project. And of course, we also involved the European Respiratory Society, which is a very large European society for healthcare professionals. As if we want to improve care, it's not only important to talk to patients and address and share our results with patients, as we are doing tonight, but also to make sure that professionals hear these results and can adapt their clinical practice accordingly. So what did we do within the COCOS project? Well, the COCOS project consisted of 3 work packages. In the first work package, we aimed to create a long list, a comprehensive list of all possibly relevant outcomes. So we wanted to be open-minded, and anything that could be of relevance for patients was included in this list. Of course, this is not workable within clinical practice. You may have a very specific need that the majority of other people will not experience. It doesn't mean that it doesn't need to receive attention, but we wanted to distillate a list that is applicable to the majority of patients. And so this is why we set up a second work package to narrow down this very long list of possible outcomes to a workable list of the key or the core important outcomes. And then finally, once we have determined the core outcome set or the key outcome set to be addressed in clinical care, we also wanted to determine how these outcomes best can be assessed within clinical care. And I will go over these 3 work packages together with you and share the main results with you. So let's first start with the first work package. As said, we wanted to have a very long list of possibly relevant health outcomes that matter to patients potentially, so to be very open-minded, very comprehensively. And we used 3 sources to come up with this list. First, we looked at the scientific literature, publications, so we conducted a review of many papers, as you see the numbers on the screen there. We looked at results or outcomes that were used in clinical trials or drug testing trials, for instance, outcomes that were addressed in, for instance, interview studies with patients. So we considered different types of studies to extract a long list of outcomes. Secondly, we also surveyed healthcare professionals across Europe. So we sent them a questionnaire asking which outcomes or aspects of the health of patients they deemed the most important, or they already used or addressed in their clinical practice. And we received back 111 responses, not only from lung specialists, but also from nurses, physiotherapists, psychologists, and other healthcare professionals who were involved in the clinical care of patients with lung fibrosis. And then a very final but very important source of information were focus groups with patients. So we conducted focus groups in 5 countries. It means also in 5 languages, because not everybody is a native speaker. So we made sure people could communicate in their own language. And we set up these focus groups in Belgium, Norway, United Kingdom, Greece, and Turkey. And again, uniquely, These focus groups were not led by psychologists or other allied health professionals, but were led by patients or their representatives. And I hope some of the moderators are here on this webinar as well. So let's have a closer look of what we did within this focus group. So we helped patients and their representatives to prepare everything for these focus groups. And Janet and Steve from ELF and EU-PFF were very instrumental in that. So we co-designed the information letter, the invitation mails, the discussion guide, and Steve and Janet also trained their peers from these 5 countries to conduct the focus groups themselves and make the reporting and give the first results back to the research team. We reached 30 people with lung fibrosis and 6 caregivers who participated in these 5 focus groups. The majority were male and 1/3 were of female gender. Also 80% had idiopathic lung fibrosis, which is among this rare disease group the most common form of lung fibrosis, and 20% had other forms of lung fibrosis. Also, we reached out to people with various stages of the disease. So some people had their diagnosis more recently, others were diagnosed a longer time ago or experienced a different degree of disease severity. So what did we ask patients during these focus groups? Well, 2 key questions. The first one, what does good health mean to you? And the opposite, what does it mean not to be in good health? And before we have a closer look at the results of these focus groups, I would like to take you a moment to reflect if you would be asked the question, which aspects of health or well-being are the most important to you? And you can write your reactions in the Q&A of this webinar. I'll give you some time to reflect. I cannot see the Q&A section, so I'm looking at Celia or Steve, who maybe can read out some comments.
I'm monitoring it. So everybody, just to repeat the question, what Fabienne would like you to do is to put into the Q&A, which you'll find at the bottom of your screen, and your answer to this question. Take a moment of reflection and answer which aspects of health or well-being are most important to you. So if you suddenly had that question put to you in a survey, what is it? What is it about health? What is it about your well-being which is most important to you? And we've got a number of people coming in already.
Yeah, we have this coming in.
But we need more of you. Come on, we want everybody on the call to answer the question if you can, please. Great. We've got 4 more coming in. That's fine. Yep. Good. These good ones. I like these answers. They're good. Should I read them out quickly afterwards, Fabienne?
Yes, that would be helpful.
Yeah. So you can't see it. I can. It's really. Should I read it out as we go, or will that bias the results? Do you think? Why don't I start? Apart from Eleni, who says hi from Greece. Hi, Eleni. We have first one, ability to do daily tasks, normal body function, the ability to breathe, being able to breathe, being active in sport and being part of a community. Very important, the part of a community part as well. My quality of life, overall quality of life, and whether I can keep doing my activities that I enjoy in life or that I need to do. Ability to work and socialize. Side effects, I guess minimizing any side effects. My mental health, my rehabilitation as far as possible. Those are the ones we've had so far. Please, if you could, let's have any more of you've got, and we'll come back to them afterwards. But please do put them in there if you can. Anybody else who would like to add to those? question. Thank you.
Another answer, Steve, it's good health to me is not just the absence of illness, but a state of balance between the body, mind, and emotions.
That's very good. Well,
yeah.
Fine.
Okay, thank you so much for the answers. And the reason why I was asking this is that hopefully you can recognize yourself in the themes we identified when talking to this group of 36 people. So a first theme that was addressed was being understood, respected and supported by the environment. Sometimes lung fibrosis is an invisible disease. You have symptoms, your physical activity is not going so well, but people don't see it or they don't notice it that you're suffering. And people really don't understand what it means to live with this disease. So feeling understood, respected, supported is of key value for patients. A second theme that was addressed is coping. So many people indicated that it's sometimes hard to deal with having this disease and this treatment. And some people really don't know how to cope with all these symptoms, the disease progression and its impact on daily life. It's a matter of resilience, finding ways to bounce back in difficult circumstances. Also, very importantly to people is being able to maintain meaningful relationships. They want to be loved, of course, everybody wants this, but they also want to love others and they take care of others, not only in a physical way, but sometimes also emotionally. Being able to get around and remain physically active, we've heard this in the chat as well, is also of key importance to people. And being able to execute day-to-day tasks. This means these are tasks everybody needs to do, like self-care tasks, but also your household activities, shopping, doing little tasks in and outside the house. So these day-to-day activities, and people want to be able to do this as long as possible. Emotional well-being was also addressed. So people dream of not feeling anxious, being optimistic, and experience joy in life. Life participation at the fullest was another theme. So people want to continue participating in social and cultural activities. And we labeled this as participation in life or life participation. And then the final major theme, there were other themes addressed, but these were the most common ones, was remaining independent, not feeling dependent from others for care or activities, and remaining in control, which is very related to feeling independent, but remaining in control of your own life. So if we look at these themes, they very much resemble of what you have written in the chat. And so asking the questions, being in good health, it means for people they want to live a normal, high quality life despite having a serious chronic disease. So what did we learn from this first phase? So the phase where we wanted to have this long list of possible outcomes based on the literature, the survey with healthcare professionals, and the focus group with patients. So in total, we identified 82 different possible outcomes to be addressed in clinical care. This is way too much, but I show them on the screen here. I will not read them out loud, but you see that we group them in 5 categories. A few aspects related to survival, like all-cause survival, disease-related survival. There was a long list of more medical or clinical aspects who had to do with symptoms such as breathlessness, cough, chest symptoms, sputum, but also like weakness, fatigue, frailty, quality of sleep, and so on. Impact of on life impact was the largest category. You see here dealing with disease progression, psychological well-being, social functioning, sexual intimacy, capability to do activities you enjoy, loneliness, anxiety, financial concerns. So it's a really very diverse list. Another category referred to resource use. It has to do with the costs, but also the occurrence of, for instance, hospitalization events, outpatient clinic visits, intensive care visits, and the cost associated with these hospitalizations or disease-related costs. And then a final group had to do with side effects and complication of the medication and the burden that comes with these side effects. And I believe this was also addressed in the chat. So as said, this is a very long list. This is not workable in clinical practice if we want to identify a key set that always should be there and always should be questioned regarding the well-being of our patients. So we need to narrow down this list, and this was done in the second work package. So the goal of the second work package was to identify the most important health aspects, or the so-called core outcome set. But before we could start the second work package, together again with patients and their representatives and people from ELF and EU-PFF, we tried to already narrow down this list, this very long list. So we had a closer look at the outcomes, the 82 outcomes, and we tried to remove overlap between concepts. Also, there were some very few outcomes that only were applicable to a very specific form of lung fibrosis, but not to the large group of people with lung fibrosis. So these outcomes were removed. It didn't mean that we pre-selected already outcomes. So it was not us who needed to determine what is important and what isn't. It was just to make it a nicer list, to reduce overlap and in a more concise way. And secondly, with the help of, for instance, Janet and Lucy, we created a definition or a description of every outcome or health aspect so that everybody understands what we mean with a given concept or a given label. So if we talk about breathlessness, everybody understands what we mean. If we talk about acute exacerbation, sexual functioning, or cognitive functioning, everybody has a clear understanding in lay language, plain language, what this outcome means. So we worked in the second phase with a list of 56 outcomes. And in order to come up with this core outcome set, we used a consensus method called the Delphi study. This was done in different rounds, and I will explain this, how it's working. And this was then closed with the consensus meeting, again involving patients, their representatives, and healthcare professionals. A Delphi study is a way to find consensus among a larger group of people by asking their opinions on the relevance of certain concepts, but this is done anonymously. So people could give an anonymous vote of what they think is important without being influenced by the opinion of others. We had in total 5 groups of participants, and each group had an equal say in reaching consensus. We had a group of lung specialists, a pulmonologist, a group of nurses, a group of other healthcare professionals, for instance, psychologists, physiotherapists, a key group of patients, and a separate group of caregivers. We again developed a questionnaire in different languages, hoping that we could reach out to as many healthcare professionals and patients, caregivers across Europe. So the languages were English, Hungarian, Spanish, German, and Turkish. And the goal there was to reduce the list of 56 outcomes and turn that into a workable core outcome set to be part of clinical care. So how does a Delphi study work? Well, we asked them not to answer for their personal situation, but to answer for the group they represent, for the patients in general. So whether it matters for patients with pulmonary fibrosis and not necessarily for their own specific situation. So this is already quite a challenging thing to do. And they received many questions. We asked them, how important is it to take the following health aspect into account in clinical care? So we started with this unique 56 outcomes. So for instance, how important is it to take breathlessness into account in clinical care? And people had to give a score from 1 to 9, ranging from not important to extremely important. The same was done for acute exacerbations, quality of dying, feelings of shame. So it was really very comprehensive list. In the first round, 110 people participated, and it was about 20-25 in each group. So we had 20-25 patients, 20-25 caregivers, and then the other participants were professionals. We started with the 56 outcomes, and in this first round, we were able to remove 8 outcomes. So what was the decision rule that was decided up front? So once 75% or more participants within a given group gave a score of 7, 8, or 9, so deemed a specific outcome important, this outcome was kept. So for instance, even if, for instance, physicians would think, well, breathlessness is not that important, this is not the case, but maybe a bad example, but patients say, no, this is absolutely of key importance for us, then the outcome would stay in. So we were quite liberal in these first phases. In the second round, we show them the remaining 48 outcomes again, but now they had access to the scores of the group, so they could see what they scored on the previous round, they could see what their group scored, and they also could see what the other groups scored. So a patient was able to see the scores of the other patients who completed the survey anonymously, but they also had access to the scores of the nurses, the lung physicians, and the other healthcare professionals and the caregivers. And we asked them to rate the outcome again using the same scale, and whether they would change their mind now that they know the scores of the other group. So, for instance, physicians might think, oh, this is less important for the care of patients, but then they see the high scores patients give, maybe they change their opinion. Or the other way around, that an outcome is scored less important because they see it's less important for other participants in this survey. And then finally, of course, we want to grow towards consensus among all groups, so both patients, caregivers, professionals. So in the final phase, it was decided up front that all groups, so 75% within all groups, should give a high score in order to be kept as a core outcome. We started with 22 outcomes, but unfortunately in the third round, we were not able to remove any further outcomes. We also asked participants to do a best worst exercise. So we showed them 2 different outcomes and asked them which one was the most important one. For instance, coming back to the example, breathlessness, or doing your daily activities. And so people had to choose, prioritize what is more important. It's both important, but what is more important, one or the other. And then we concluded this exercise by a consensus meeting in which patients, caregivers, and professionals from all over Europe participated to decide upon the final core outcome set. So for 17 outcomes, there was already consensus. It was very clear that this would be the core outcome, and this would make it to the core outcome set. But for some other outcomes, there was no clear consensus among groups. It was important, but some did not reach the threshold of 75% importance. So one of these aspects, I will have a look, was, for instance, fatigue or quality of sleep. I think all of you agree this is important, but then it was discussed, and after a vote, it was decided not to keep this, as fatigue probably is already covered in other outcomes that made it to the core outcome set. You probably are very curious to know what this final set of outcomes is. So in total, we had 17 outcomes that should become part of standard care for people with lung fibrosis across Europe. And we used an acronym standards IPF or PPF care. So these letters stand for satisfaction with life, satisfaction with care, treatment adherence, so being able to follow the complex regimen and all the medication as prescribed, ability to do activities you enjoy, nutritional status, being knowledgeable about disease and treatment, activities of daily living, resilience, also referred to as coping, dyspnea, which is the medical term for shortness of breath, independence, physical activity, pulmonary function or lung function, feelings of anxiety, cough, acute exacerbations or flare-ups of the disease, reaction to treatment, which is referring to the complications and side effects of treatment, and then finally, exercise capacity. So what you're capable of doing, whereas physical activity more refers to what you're actually doing in your daily life. So this is the list of 17 outcomes. So we successfully concluded work package 2, and now it was time to determine how we can best assess these core outcomes in a daily routine. So this was the last work package. There again, we set some criteria up front. So if we select a measurement method, it should be a reliable one, a valid one. It should be a meaningful one. So capturing the outcome we wanted to measure. We always wanted to take the preferences of patients and healthcare professionals into consideration. And for some measures, it's not possible to offer them for free. But if you go for questionnaires to capture some of these outcomes, for us, it was important that they were as short as possible and could also be used for free so that you don't need to pay per copy you're completing within clinical practice. How did we do that? Well, for each of these 17 outcomes, we created first a very long list of possible measures to address this specific outcome. And with all these pre-specified criteria, we narrowed down that list to 2-3 candidate measures. For the clinical measures, we reached out to professionals to determine the best measure, but for the more patient-focused outcomes on symptoms, on well-being or impact on social life and so on, we set up 2 focus groups, again with international patient representatives, to help us select the best measure possible. So all participants reviewed these questionnaires, made comments, which we discussed during these focus groups, and then it was determined what was the best option to move forward. Then finally, the entire COCOS project team met to endorse the final selection of measures. And as said, these were not only professionals, but also representatives or partners from ELF and EU-PFF. Just to give you some examples, we will not go over all measures, this would take us too long, but just to give you some examples how this could look like. And probably the first one you know already, which is the lung function test. I believe many of you, every time they go to clinic, they complete the lung function test. This, of course, this cannot be done for free, but it is a useful instrument during routine practice to discuss how you're doing and whether there's any evolution from the previous assessments. A second one is exercise capacity. For this, it was decided to use the 6-minute walk test. And again, some of you may have completed this test. This is a test in which a healthcare professional is asking you to walk for 6 minutes as fast as you can in a long corridor of 10 or 30 meters. And then they count the distance you cover and they compare that to some norm data for people of your age or your gender. So you know this test to determine how capable you are to do physical activity. Another one, which is more, these were clinical tests. We turn into questionnaires. Another one is shortness of breath. There were many candidate questionnaires, some were a bit longer, but at the end it was decided that 2 questions would do the job. Here you see these questions. Overall, how severe was your breathlessness in the past week during the day? And it was also discussed that we need to make a distinction between symptoms during the day and symptoms at night, because this could be a difference. So the same question was asked for symptoms or breathlessness in the past week at night on a 10-point scale, going from not at all breathless to the worst thinkable breathlessness. And then, for instance, satisfaction with life. Again, not that easy to find a questionnaire, but at the end, we were able to come up with a single question that includes everything. So thinking about your own life and personal circumstances, how satisfied are you with your life as a whole? Going from not satisfied at all to completely satisfied. And then finally, the last example I would like to show you is anxiety. Again, there are many questionnaires out there that assess symptoms of anxiety, but we selected one that is valid and that is short and exists in different languages, asking you about symptoms in the last 2 weeks, how often you have been bothered by the following problems: feeling nervous, anxious, or on edge, or not being able to stop or control worrying. And if you reach a certain threshold, then clinicians can ask you further questions to understand what is the nature of this anxiety or what is causing this anxiety. The reason why I show you these examples is to illustrate that we really paid attention to easy to understand questions and short questions, because if you need to address 17 outcomes during the consultation, we need to make sure we don't park people in the clinic for hours just completing questionnaires. So this is how we want to do it. Of course, another question that needs to be addressed is how often should these measures be completed? And we just want to give you one example how this could work, but of course, clinics are free to determine their own pace of assessment. So, for instance, it can be interesting to do the following tests at every visit, and I believe many of you have a hospital visit every 3 to 4 months. So lung function test, checking whether you had a flare-up of the disease or an exacerbation or the complications or side effects of the treatment. This is probably already part of standard follow-up. So nothing is changing there, but it's key that this has been done for everybody if this is not yet the case. And so if you then would ask people about the shortness of breath or cough, it would only take 3 minutes extra of the time. People can complete the questionnaire while waiting in the hospital. So it's not taking up a lot of time there. Things that could be assessed twice a year. This would mean filling in questionnaires for roughly 20 minutes to document impacts of your disease on activities of daily living, coping or resilience, anxiety, treatment adherence, and satisfaction with life. And then annually, it's probably enough to have like this 6-minute walk test, look at your nutritional status, and then perhaps only complete the questionnaire on knowledge about your disease and treatment, physical activity, and satisfaction with care overall. So if you plan carefully, it doesn't burden patients in return for a lot of extra information on how they are doing, not only from a medical perspective, but also looking at their non-medical needs in view of psychological well-being, social functioning, and so on. Of course, the goal of the entire project is not only to complete questionnaires and document the needs of our patients. So our ultimate goal is offering extra support where patients need it. And just to give a few examples what this could mean, well, we hope that if physical activity is assessed regularly during clinical follow-up, that clinicians will then decide what can be done to help people in increasing their physical activity or maintain their level of physical activity. So one might consider referring their patients to a rehabilitation program, or perhaps to a physiotherapist closer to the homes of a patient. Or there might also be like community services, trying to find a walking buddy who can take you out for a small, easy, lazy walk, so to remain as active as possible. But there might be other options as well. Key here is that we always take the capability of a patient into consideration, but again, the preference of the person. It's not only the clinician, the healthcare professional deciding, oh, we should do this or that. People need to have a say in what they want and what they need. Another example, and that's the final example, relates to anxiety. So if you have symptoms of anxiety, options could be to follow a relaxation program or a training in meditation, finding ways for distraction, remaining physically active, because this is also helping to distract your mind, leading a healthy lifestyle. If anxiety is really serious, then it might be helpful to be referred to a psychologist for some therapy. In some cases, medication might be needed. But again, it's based on what people need and what people want. It's not only the healthcare professional determining the treatment plan. So again, our mission is to develop a model of care that provides supports to people's medical and non-medical needs across Europe. So what are our take-home messages for you? I hope that if we start using the core outcome set and its measures, that this will improve the care for people with lung fibrosis across Europe, and that these non-medical needs will finally also be addressed. The development of this core outcome set would not have been possible without a close collaboration with patients. If we would have done the same thing with professionals only, we would have ended up with a completely different outcome set that maybe would be relevant for clinical research, but would not probably be applicable for patients in clinical care. We hope that this webinar is a first step to talk about this core outcome set with your own treatment team, so that they can understand which medical and non-medical outcomes you value the most within your care. And as a sneak preview, we also, together with Lucy and Janet of ELF, a summary in plain language and an infographic summarizing the main findings of our project, which also can help you to start the discussions with your treatment team. And this will soon be made available again in different languages, so that it's easier to spread the word. And let me conclude by expressing a warm thank you to all the patients and caregivers who contributed to this project. Without you, it would not have been a success. So thank you on behalf of the entire team. So these are our conclusions. I wonder, I'm very curious to know which messages are you taking home after this presentation. And we are, of course, happy to address any questions you might have after listening. Thank you so much for being here, and I hope together we can change the way you're cared for in Europe.
Great. Thank you very much indeed, Fabienne, for such a clear explanation of what was a very, very complicated project. Lots of clap signs coming up on the side of the screen. Yeah, I think for everybody in the audience now, this is the time to put your questions into the Q&A. Please, as I said, make them brief, make them succinct, and we'll get through as many of them as we can today. If there are any that we don't have time to get to today, then we will be able to arrange for them to be done and answered by Fabienne and Celia later. While you're thinking about the questions and entering into the Q&A, Celia, is there anything you'd like to add to this? I mean, are there any other perspectives that you'd like to give us?
Yeah, so I think I actually have a question because Fabienne, thank you very much for this really very nice presentation of the project, and I had some very great memories coming up, going through all the steps that we did
Right.
together. And one thing I remember very vividly and very positively from our project are the constructive and vivid discussions that we had in the research team. So with the doctors, psychologists, the patients. And one aspect I remember we discussed very intensively was survival as an outcome. And I could imagine that some people might be wondering why survival is not in the core outcome set.
Yeah, indeed. And I think you remember Celia, and I think also the other team members that are here, that we expected that survival would be of key importance to people. And it turned out very quickly within the Delphi study that it wasn't. So people, for them, of course, it's important. They want to have a long life as long as possible, but it's less important than having a good quality of life. So the quantity is less important than quality. And this is why it was not scored that highly. And it was not just one individual, it was the group that decided that this was less relevant. And I think that changed also the minds of physicians, of clinicians who always think we need to give them the longest life possible. But it's also a shift in mindset that sometimes this is not the key outcome, that other things matter most to people. And I hope this is something that participants recognize here.
Great. I've got a couple of really quite interesting questions. First, a comment. The take-home message for this person is holistic and multidisciplinary approaches are key to lung fibrosis, to managing lung fibrosis. Absolutely right. And I think certainly the takeaway I took from working on this is a holistic and multidisciplinary approach, which we could come back to in terms of how that is organized and the way the treatment is organized. But a good question from a colleague from the ELF PAG and also soon from EU-PFF. What concrete actions should healthcare systems take to translate these patient priorities into everyday clinical practice? I mean, you've presented them. We've got the 17. We've got probably maybe 25 different ways of measuring those 17 indicators. What next?
Yeah, I think that's a very good question. So majority of the findings are already published, and we are now working on the final manuscripts, which we will present a measure, ideal measure per outcome. So it will not be something professionals need to choose from. Of course, for some measures, it's not the ideal word, but at least we will have a set of measures ready for this core outcome set. We will also indicate whether a translation is available, and if not, how you can organize a translation yourself. But I think the key thing is that we hope there's an openness of teams to look at this data and see how they can fit this within their clinical routine. It shouldn't be that complicated. That's why I showed you the possible example of how you could do that. It's a misunderstanding that this will cost many resources or time. I think it should hopefully create a shift in mindset that doing things differently might be the solution or the way forward. But of course, you're right. I think, and hopefully in future options to collaborate, we need to work on really determining how these models of care should be or best implemented and tested, whether this is working or not.
Okay, I think that's a really good response. I think I can see clinicians sitting around working out what their algorithm is for treating a patient. They already have it. They work through certain steps, and what we're doing is making sure at certain points, new questions or questions they might not have had asked down. There's a checklist that they can then begin to follow and say that's important. Check on that. And I think good physicians, almost everything here would be normal. Experienced physicians, they would generally ask these questions, but it's so easy when you're rushed to forget important things. Yeah. And it's hugely important. So I get it from that perspective, how this is a set for clinicians. How should patients use it?
Yeah. I think it can also be, if they are aware of the existence of the core outcome set, it can also be a check for themselves. So even if it's not directly addressed in clinical practice, if they know the measures, and I think, again, together we can have a look how we can do that, probably they can do like a self-assessment. And then for those things that they want to discuss, they bring it, or they open up the discussion with their clinicians. So empower them to speak about their unmet needs.
So the project is going to produce media for patients, social
Yes.
media, things that will help them do this,
Well,
YouTube
yeah.
videos and such like, so that patients can turn to that and say, if you've got an appointment with your clinician, here are things you might want to talk about.
Yeah, that's the goal of the lay summary and the infographic. So as like a 2-page summary, so that they can start discussing these aspects with their team, so that clinicians become aware, professionals become aware of this core outcome set. And so hopefully then they will have a look at how this can be addressed, how this can be assessed. But the goal of the project was too short to immediately also give some insights on how certain needs need to be addressed, because it depends on the personnel you have available, the resources you have available, but it should not be just a questionnaire. Something needs to be done with it. That's really our hope.
Yeah, I think it's really important. I think there's clearly a role there. I mean, it's not the project's role to produce, say, the YouTube videos, but if in national patient organizations feel this is important, it's a job for us to do in our home languages in whatever is the most effective way, both to educate patients and also, healthcare professionals working with patients.
Yeah.
I mean, an interesting question here, again from Eleni in Greece, is which patient concerns were most frequently underreported by clinicians compared to what patients actually experience in daily life? So in other words, what differences were there between what the clinicians thought were important for patients and what patients thought were important for patients?
We don't have real data on like prevalence of certain needs, but I think that the example that was given by Celia Survival was one that was very surprising to us. We also had a vivid discussion on imaging, what people could see, and because there we sometimes had like mixed feelings on what's the added value. The same for lung function. I think for patients, it's something that is valuable because it gives them like something, a tangible thing to monitor their disease and the progression. Whereas for clinicians, if they would have the choice, it's sometimes mandatory to have it for a registry, but it's not something they learn much about it. They have other ways to look at severity of the disease, but that was the compromise we had. So there was some debate in all different directions. But I think the clinicians, in all honesty, the physicians learned a lot from what matters really to patients. So there were a lot of outcomes they have never thought of that this would matter to people. And I see this in other projects or in other circumstances as well, that, for instance, they have a whole checklist of what people can do, like activities of daily living, but they forget to also ask questions on, can you still do the activities you enjoy? Are you able to take care of your family? So that these aspects are often not part of an assessment.
That's great. No, thank you very much. Just for the audience, I think we'll go on for another 5 minutes or so, because I think there are one or two interesting questions still. We're going a little bit past 7 o'clock. I hope you can all stay. The other question that's come up is, there's a frequency of visits. You implied this, what to do in a quarterly visit, a 6-monthly visit, an annual visit. That's not the way it works. In the first years when you've just been diagnosed, you maybe have very early stage disease. You may only see somebody once a year, and the changes will be in your quality of life, etc., will be very limited at that time. They'll still be going on, but generally speaking, might be quite slow. As you progress on, the doctor is going to want to see you more often. So you might go down to being seen every 6 months. You might come to being seen every 3 months. But if you're not seen every 3 months, it would mean on the 6 monthly visits, they would want to do almost everything. And if they think that a 6-minute walk test is needed, which I certainly had very often when I was with IPF, that would be part of your visit along with your PF, with your lung function test and other things. So I think that way you seem to sound to me a little bit mechanistic. I don't think that's the way life operates for.
I think it very much depends on the country where you're receiving care. I know, for instance, in Belgium, people are seen every 3 months, and this has to do also with reimbursement of medication. This might be the case in some other countries as well. But I think in any case, even if you're seen only once a year by a pulmonary fibrosis expert, because that's what we are talking about, even if it's on a yearly basis, and you have to complete all questionnaires at once, it would only take like 45 minutes to have like a full assessment. So that's the selection we made, and of course it's still 45 minutes, but we think it's a meaningful 45 minutes because it gives you a clear understanding where you are, and it gives professionals also insight on where is support needed. Support that might not be available within the clinic, but maybe in the community, or can be offered through support groups by patient organizations who are doing a fantastic job across Europe.
Indeed, yeah. I mean, that's another question that one patient said they were surprised that there was no mention of peer support in the talk. That, you know, for example, not just face-to-face patient groups, but also Facebook and WhatsApp, hugely important. I mean, this person is talking about their experience in the UK, in 2 different parts of the UK, where there are, you know, over 100 people on a WhatsApp group in the southwest of England, 20 around Oxford. You know, they're working all the time, and I'm a member of 2 or 3 Facebook and WhatsApp groups that go on, and hugely people get their support and they get their information in so many different ways.
Yeah. Yeah, and it's, I think I only gave 2 examples of how certain outcomes could be addressed, and you're absolutely right. I think that the patient advocacy organizations could do a wonderful job in working with this, but sometimes for some people this might not be enough. For instance, thinking of anxiety, it might be helpful to know that other people experience the same struggles. And you can receive some tips or tricks how to deal with it that are very helpful. But once it gets serious and you suffer tremendously with a high impact on your daily functioning, then something else might be needed that you can't find within peer support. So then professional help might be needed.
Of course, if they're not, just alone is not enough. Yeah. I mean, I think the word that we're using increasingly in the UK now is about integrated care.
Yeah,
I mean, generally speaking, the patients I talk to here, if you're lucky enough to be in one of the 24 specialist centres in England, you'll get very high quality care universally. If you're in other hospitals, it may be less good, but we're working hard to make the standard of care across everywhere. But that's medical care. Now, all the people giving you that care will talk about the other things that are important, like pulmonary rehabilitation, like psychological support, oxygen, end-of-life planning, you know, the side effects management, which they will generally deal with, but not always if it's sometimes with cough and things. But the real difficulty is how you integrate this. Who is responsible for ensuring that integration to benefit patients? And that's what worries me. I don't think we have a system where, you know, the people in the main ILD centre will not feel responsibility. They'll say, go to your GP, go to your community nurse. You know, and they will devolve the responsibility without checking later. And when it goes wrong, where does accountability lie? You know, I think there are really important questions here, but I think this work will really help. Sylvia, one last chance. Anything else you'd like to add?
Yeah, so for me, it was a very, very interesting experience working in this multidisciplinary team, and with this lot of methodologies that we used over the 3 years. So I definitely take a lot with me from this project. And Fabienne, I have one last question, which would be, what would be your take-home message for research groups who are planning similar projects, who want to put a co-design approach at the core of their project?
Yeah, I think the key to success is to set up, as I said, a multidisciplinary team and give patients or their representatives an equal voice as a co-investigator. It's sometimes a lot of discussion, but I think that's absolutely needed to be successful.
Discussion is a euphemism for the arguments we used to have. Putting a patient perspective and asking for changes. But it was good. It was extremely good and productive. Finally, I think there's a wonderful, somebody said, they've got a rush, but millions of congratulations. What a great job. So I think that summarizes everything. Thank you very much indeed, Fabian. Thank you, Celia, for coming as well. I think this is going to be hugely important. We're just at the beginning of where we work out together how we can make use of this in patient care, both from the clinician's point of view, but also from us in patient advocacy organizations. So thank you very much for all you've done. Thank you for tonight. Thank you for the questions we've had. Have I missed any from the... I've one or two interesting points. You will see these afterwards anyway. But thank you to all the people who've participated tonight as well, and to Alba and the team who made this possible from EU-PFF. ELF have done a brilliant job, have been wonderful to work with. So have a nice evening, everybody. Thanks very much, Fabian and Celia. I look forward to maybe you coming back sometime and we'll talk about how this has been turned into reality. So thanks very much indeed. Thank you. Great.